yes, you might feel that I'm a proponent for alloplastic reconstruction. Uh, when I say this, that I'm a proponent for alloplastic reconstruction, it doesn't mean that I would give away saying vascularized grafts don't have a stay, especially the ones what you spoke about, the fibula or the medial femoral condyle osteocartilaginous flap. At this point, I would like to ask you, has the author done justice with regards to the use of the medial femoral condyle osteocartilaginous flap in a case like osteochondroma? You, in your discussion, spoke about osteochondroma and osteoma. You spoke about your osteochondroma and use of these flaps in osteoma and osteochondroma. Do you think that these kind of cases of osteoma and osteochondroma really demand such a massive kind of flap like the medial femoral osteocartilaginous flap, where you have to spend so many hours, so much time anastomosing it? Yes, it's an innovative technique. This is just to start off with the discussion. It's just a discussion. Don't think that I'm putting down the MFC. The MFC is a good flap. Server, would you agree with me that a tumor like osteochondroma or an osteoma can be managed much better based on the size of the defect, as Akash put it up? What's your view on that?
In terms of like reconstruction of the TM joint, even in the benign tumors, yes, definitely it's required the proper reconstruction where the anatomic form and function of an individual can be achieved successfully. But since it's a new technique and it needs like little bit proper training, and despite of training, the important thing is the microvascular part is also included in this work because of the composite graft. So it's started like open a new chapter in the field of oral and maxillofacial surgeon. Not only oral maxillofacial surgeon, some other specialties. Even the plastic surgeon and the ENT surgeon can also go through it along with the orthopedic surgeon. So I think it's a good thing, and it's open to everyone to like think about a new reconstruction strategies or the options. Although in the present scenario, like we are using the available things without the microvascular reconstruction, so like it's a interesting thing to like think about these new strategies or new options available in the when you talk about the young and the like budding maxillofacial surgeons, so they can think about the new options available. Although the preciseness of the surgery or the training of the surgery is very important, so we can promote this thing if it is like feasible for all of us. Yes.
Yeah, I would agree with you, Sarwar. But from a discussion point of view, what I would like to get into is that the author's selection of cases, what they have selected is an osteochondroma and an osteoma and a type 4 TMJ ankylosis case. Whether the other shortcoming, what I see from the study as a point of discussion is when you're saying a TMJ ankylosis, the type 4, and you will know that Sony's type 4 is a bad case of ankylosis extending to the medial skull base, and the author has not spoken about any kind of ankylosis, whether that ankylosis was secondary to trauma or whether it was associated with any facial asymmetry. Because remember that the evaluation done by the author is not objective, it is all subjective based. It is all subjective, where the author has taken scores from the patient itself rather than an objective scoring system. Where yes, if there is a facial asymmetry, if Sarwar Hashmi sees the facial asymmetry, giving a score of 1, and Abhay Kamath and Akash also see the score and they give it as 1, it is standardized. That is one point what I would say. And regarding the osteocartilaginous flap, yes, it is good. It's opened a new chapter by itself. As you said, I would agree. Seeing that one particular case, what Akash put up from the author's opinion, where they've used it for an osteochondroma. And you know that osteochondroma is a benign tumor of the TMJ. And if you see the incidence of literature of benign tumors, there is very limited resource of articles in the net on tumors of the TMJ, whether it is osteochondroma or an osteoma. Whereas the same Chinese group also proposed, I'm acting as the devil here, let me be honest. The same Chinese group also proposed a vertical sliding osteotomy for in cases where there was a size variation lesser than what the author has used, where the proximal segment would slide up and become the artificial condyle and the lower basal border would be grafted from a discussion point of view. And the other thing, what the author has done is, in spite of doing this particular flap of the MFC, he's also interposed the temporalis myofascial flap. So going back to the limitations and what Akash spoke, are we doing too much for a small case like an osteoma or an osteochondroma is my take on this server. What do you feel? Just as a discussion point.
Definitely not. Definitely not, because we have some other options available to do the job in a proper way with a limited time period.
Absolutely.
With a small time period. While taking this graph, because it's the pure, the composite graph where the resection and the microvascular anastomosis is also required. So when we have the options to reconstruct the these kind of benign tumor lesion of the joint with the help of some available reconstructive options, so definitely we are not promoting this this flap for that special or the routine type of the benign tumor of the joint tumor reconstruction. So definitely not. I'm not not promote this flap for the small reconstruction of the small tumor.
Yeah, as a discussion for the journal club. So Akash, one question to you from a postgraduate level point of view.
Yes.
Akash, you're there?
Yes, sir.
Akash, if you can review as to what would be an ideal source of reconstruction for a temporomandibular joint affliction with regards to an ankylosis in a child who comes to you, what would be the ideal take of grafts for these kind of children?
Sir, I feel we can go for sternoclavicular joint because it resembles it from the point of histological as well as anatomical point of view. It resembles the cartilage of the TMJ, as well as the potential complications that were seen in the costochondral graft that are ideally used are done away with. Like in that costochondral graft, there was a potential for overgrowth, which is not being seen in this studies, in the studies of sternoclavicular joint grafts. And also the chances of pneumothorax or pleural tear, it is less. And also there is a chance of the cartilaginous cap coming out from separating from the bone in the case of costochondral graft. And the success rate, according to Wolford, has also been considered to be 93% of sternoclavicular graft. So if I will, so from my point of view, I think I'll go with sternoclavicular joint graft. However, sir, there is a complication of clavicle fracture, which is a major complication, but the success rate is more.
I would agree with you that sternoclavicular grafts are good, but another component or a point what you need to remember is when you're doing your costochondral grafting for children so that it's an autogenous source of material, keeping the surgical practices very simple to avoid an overgrowth or a re-ankylosis in patients who have undergone costochondral grafting. The ideal thickness of the cartilaginous cap to be retained according to Saeed et al. Is less than 1 to 1.5, which prevents an overgrowth leading to a recurring ankylosis. Now, in these patients, what you have spoken about in osteoma, according to the author, he's also done an MFC. And the defect size was somewhere close to 3 centimeters or 4 centimeters for the osteoma. Was it so?
Yes.
Yeah.
Sir.
For a defect of 3 to 4 centimeters, doing a medial femoral osteocartilaginous flap, what I would see it as a critical analysis of the article, and the success rate definitely yes. As I was speaking to your head of the department, Dr. Sarwar, I'm not against the medial femoral condyle. It's a good innovation for the young budding or maxillofacial surgeons. But as you pointed it out, there is a long learning curve, a microvascular anastomosis which needs to be done. But from an Indian scenario where we are having our microvascular training in particular areas at that given particular point, at that center, wherever the surgeon is working, whether there is availability of the setup is what needs to be considered. When you see all this and put it in a nutshell, I would keep the principles of surgical practice very simple.
Yes.
Whether we can get away with the costochondral graft in a young child and anything about 12 years of age, whether you can do a proximal osteotomy and reconstruct that is an option what we can try. And you also spoke about availability of TJR or joints in the Indian scenario regarding their expenses, regarding the availability. Let me tell you today, if you're thinking about joint replacements for these kind of cases, what has been projected by the author on ankylosis and osteoma and osteochondroma, TJRs have a longer type of sustainability because the author here has used it in a case of ankylosis. Whether the ankylosis did happen after the growth period was over, we don't know. Number one.
Yes. Yes.
He's only mentioned it saying that he's used it in a type 4 ankylosis. And when these patients present to you with an ankylosis at an early age, you will also come across certain amount of facial asymmetry. That's why I said the assessment by the author based on the facial symmetry, he's done a subjective analysis. He's not been doing an objective analysis where the same team of surgeons should have been assessing the patient for one, facial symmetry, masticatory ability. When I say masticatory ability, it also takes into consideration the dietary scores. Again, the paper laid down by Andrew Sidebottom et al., where they've spoken about success criteria for temporomandibular joint enhancement of functions aesthetics, where they take into consideration the dietary score. Anything less than 5 out of 10 is considered as not a success rate for a TJR. Similarly, here the authors have taken directly an objective-based questionnaire. They've asked the patient where they should have told, yes, it's going to be a subjective-based, whereas an objective-based is what they should have been doing. The same team of surgeons should have laid down criteria saying, okay, this is what is the facial asymmetry or the facial symmetry score, the dietary score. So that's another major shortcoming, and the LEFC scores, what they gave. Again, it's going to be subjective. So all in all, if you see, this is this is an article which is good in its innovation. As I was telling Sarwar, it's good. There's no doubt, because it's one of the most challenging things of reconstruction. It's a very innovative idea, but we need to decipher and understand whether these outcomes, what the author has mentioned is, are we justifying the use of this flap? And you said there's a long learning curve.
Yes, definitely.
And you are talking about the medial femoral condyle. Anything about the functions of the medial femoral condyle when you raise these flaps? Akash, have you dwelled into a cross analysis of other articles where they've spoken about medial femoral condyle and its function?
Sir, the main point I found out that many authors like Zeman et al. Had as part of the donor site morbidity, they hypothesized that there might be a knee joint dysfunction, knee joint impairment, because since the medial collateral ligament was close to the harvest site as well as the knee joint was close to it. But till now, they haven't found, either there has not been any much research or they haven't found any case report which has suggested any knee joint. However, sir, in articles have found that they have found in some cases there have been pain and numbness due to the saphenous distribution of the nerve here, and which can be moderate or constant pain, and which is the most common complication, this pain and numbness. And also some less common complications include like there have been infection, hematoma, as well as supracondylar fractures as well, sir. And but this pain and numbness score was initially, as quoted by Kedavas in 2008, according to an article, it was about 19 to 60%, if I'm not wrong, sir. But now the study done by Zeman in 2018, it had reduced to 8%. They were considering it 8%, like this pain and numbness, maybe due to the efficiency of techniques and the procedure of harvest. This score has reduced, but these complications did arise.
Okay. So if I can ask you, should the medial femoral condyle flap be recognized as a reconstruction option for any other head and neck reconstruction surgeries as well? Or owing to its short pedicle and limited bone, you want to keep it only for TMJ reconstruction?
No, sir. According to an article by an Austrian authors, like they have already utilized this flap being utilized in the TMJ is something new, but it has already been utilized in the head and neck region for the reconstruction of orbit as well as forehead as well as even sir, I have pictures also to suggest my claim that they have also made airway reconstruction. They have completed the airway reconstruction by reconstructing trachea. I have pictures from some articles. So if you like give me permission,
No,
I
no,
can show.
it's fine. I'm just
Yes.
seeing the feasibility of this medial femoral condyle flap.
Yes.
Whether the postgraduates here who are sitting with us are understanding what we are discussing, what me, server, and you are putting across to them, because we need to give a message saying that is this flap, the medial femoral condylar flap, is it here to stay with us? Is it going to change the way we think upon TMJ reconstructions? Or is it an overkill what we are doing based on a case study of four patients?
Yes, sir. Yes.
If it was if it was a prospective analysis and if the sample size was much more with good objective based questionnaire studies, yes, there is a good trend. Possibly for me, the article is okay from an innovative point of view, but it has its own major limitations.
Yes,
Here,
sir.
it's not me speaking because I do a lot of TMJ replacements. It's because I'm a layman who doesn't know what is an MFC. Any other reconstruction options you can find very close to those kind of areas where we are doing the TMJ? Any other reconstruction options other than the MFC, which is much more a viable option and a feasible option?
Sir, as part of autogenous reconstruction, already costochondral graft, sternoclavicular joint, posterior border of ramus, coronoid process, these have iliac crest, these have already been utilized, sir. And
Any other areas which you would dwell upon other than these, which you think about are worthwhile going into other than the medial femoral condyle?
so if we take the femur, this lateral femoral condyle has also been explored by NCM in
Absolutely.
2018.
So they have taken both the lateral and the medial femoral condyle. If you see the paper from the Japanese group, again, as you said, the plastic and reconstructive group, in the journal of PRS, they have used this article, your medial femoral condylar flap, as an extension for reconstruction of temporomandibular joint replacements. Now, if I have to ask you two questions, tomorrow when you get out from the course, once you're done, and you want to do more of your core specialization being temporomandibular joint reconstruction, and you have a patient coming to you with a certain amount of, I wouldn't say osteochondroma or an osteoma, because I'm sure surgeons across India would have all treated osteomas and osteochondromas, where the size may be 3 or a 6 or an 8, where you're going to remove only the peripheral component of the osteochondroma, which is either protruding medially or lateromedially. You also need to take into consideration the mirroring of the right side to the left side, which you spoke about in your article. Excellent. That's the way we go ahead. So in these kind of cases, what other than the medial femoral condylar flap would you agree for reconstruction? Would you consider even a alloplastic TJR if it's available from a consultant point of view tomorrow?
Sir, if the cost point can be taken care of, I think it can be utilized, sir, because it reduces the second surgery. There is no complication of donor site morbidity, sir, and also it can be utilized, sir, but the cost is a point and availability is also a point.
Akash, the costing of an alloplastic TJR, I'm sure Darpan is around listening to us. He will cut it. He'll cut the cost down and give us joints at a cheaper rate for all the Indian surgeons, as well as the Indian surgeons are now more into alloplastic TMJ, TJR. What I see when I started way back in 2014, I feel alloplastic TJR is a lot feasible option, especially when you have these kind of cases. Now, what are you trying to do after reconstruction? Why do you need to reconstruct the temporomandibular joint? Once you have resected the TMJ, the main prime reason you're reconstructing is for function, aesthetics, and having a posterior stop. Would you agree with me?
Yes, sir.
Yes.
Definitely, sir.
In the author's experience, he's spoken about the type 4 ankylosis. Whether there was a facial asymmetry associated with that, we don't know. If the facial asymmetry was associated with the facial asymmetry, I still feel possibly an alloplastic joint replacement would have been a much better option with the possible counterclockwise based on the occlusal plane angle or the mandibular plane angle. No, I'm looking at various types of options which are there rather than concentrating only on a medial femoral condyle. Sarwar, would you agree with me on this point?
Yes, sir, definitely. For the reconstruction of the small tumor where the dimension is already defined for precise reconstruction, as you mentioned, we can go through for some other options, because for a small reconstruction, taking this long bone with the composite muscles, nerves, everything, and then the microvascular anastomosis, it's a good thing for the newcomer to open a channel to all the young and the budding maxillofacial surgeons. But when we talk about the existing available options, since we have already lots of options available for the TM joint reconstruction, so we can think about the earlier existing options also.
Dr. Abhay and Dr. Sarwar, I would like to chip in at this point. I think Amit has also asked a very valid question. This is something new that they're trying. Yeah, this is a new technique, and they're trying to see if we can achieve a cartilaginous composite structure back in TMJ. So I think it will be, anybody would like to try out a new technique with a smaller, confined and a benign defect, wherein they know that after excision, you have disease under control, and they're trying to put in a new flap. So I think that is the reason why, and it's only a case series, they're just starting out, so they don't know. And from their time of assessing these patients, they've actually given away their results. And I think they're also trying to see, and those are the questions I think Amit would like to ask. Amit, I noticed that you have a question. Yeah.
Hi.
Hi, Amit. Yes.
It was nice discussion. You are a bag of studies and experiences in TMJ and condyle. So without wasting this time, I would like to add one point. Like, for example, it depends upon the kind of reconstructions these people have elucidated. So it is basically like they may be having resources for doing these kind of reconstructions, and they may be having skills for doing these kind of reconstructions. So this goes well in their hands. So my question was just I was just posing some questions for the sake of discussion. Does this flap, the cartilaginous flap, they pose better chances for muscle attachment? Because since it is not an alloplastic thing, it is a tissue. So maybe it will pose more better chances for muscle attachment. And if there are more better chances for muscle attachment to the head of the condyle or to the TMJ apparatus, will it prove to be more efficient as far as TMJ movements are concerned? Or will they behave similarly in the case of internal derangement in future? Just for the sake of discussion, Abhay.
Yes, fantastic. Good. You added a spice into the discussion. This brings me back to the paper by Morris Momatz et al., where they do suspension of the lateral pterygoid to his existing alloplastic TJR. And I would not disagree with you at all, because the author in this paper has clearly spoken about that the graft has got a cortical component, a cancellous component, as well as an articular component. And whether you can hitch the entire muscle there, and if the patient can have a lateral excursion tomorrow, you're doing wonders to the patient. Because you remember, the temporomandibular joint alloplastic material, I'm sure you're doing a lot of TJRs, is giving you only an opening and closing. There's no lateral excursion at all. So this can be a boon if the muscle attachments can be re-anastomosed to the existing microvascular flap, number one. And regarding the component, but tell me one thing. I also wanted to ask Akash this, because we are having a discussion from a PG point of view. You raised this question whether this flap, if there is a muscle component, might prove as a boon or bane, because you might be using it and internal derangement, can it happen there? We don't know. It can happen. A myofascial kind of pain or any kind of first bite syndrome, which we normally see in our TJR patients. We don't know. Time is the only thing. As Yash and you put it across, it's a good paper, Amit. I'm not saying it's a bad paper. As you said, it's their center where they have the resources, they have the expertise, they have the learning curve is already done. And these are centers, remember, who have been doing microvascular for years together. But from an Indian scenario, if you ask me, Abhay, would you do this flap? I would think twice, especially in a TMJ. And if I ask you the same question, Amit, would you do? Yes, you are comfortable because you have been into that core area. You are doing your microvascular anastomosis. The learning curve is something which our Indian surgeons need to understand regarding the training aspect of microvascular. But from a postgraduate perspective, if I keep it very simple on this paper, my take-home message is, yes, it's a nice paper, nice article to be read into theory and then wait for time to tell us at least a retrospective analysis of at least 50 to 100 cases from one single center. You as the editor of our maxillofacial journey, from our oral surgery journey, you have done wonders for the paper, for the journal. Let me congratulate you. But I would say that from my editor's point of view, I'm sure you can give your opinion as to what would be the success criteria to say that, yes, this medial femoral condyle flap is out there for people to use. Would we still rely upon these 4 cases, Amit, or is there a criteria to say that any study holds its level 1 evidence based on the sample size? Because every single paper I go through, at the end of conclusion, it says we need to do, the cohort study needs to be extended much more because of the reduced sample size. When are we saying, yes, this is what is ideal?
So you have put it right, Abhay. So this is this article and this concept is still in the inception stage. So as you mentioned, there are innumerable number of factors which can, let us talk about the editors are always looking for new papers. The editors are always looking for unique studies and unique papers, unique case series. So as you said, the level of evidence is less because a number of cases are few. But since it is a new technique, it is a new innovation. So that holds, in the preview of every journal to accept these kind of articles with little modifications and improvements. So,
Okay.
So this article does not have a power of the study. Maybe still the long-term effects of this innovative technique and functional aspects of the TMJ, as well as the anatomical and functional aspects of the TMJ are not yet proved, because the long-term follow-up has to be there and more number of cases have to be there to see and to document all possible complications and all possible improvements which authors can do. Author can give in the next paper as caveats
Correct.
for the
Absolutely.
public. Yeah. So
Very good.
whether it has changed your mind, the critical constructive analysis is whether it has changed your mind, the clinicians who are doing TJR, whether it has changed their mind to adopt this technique feasibly in their practice. If they have not, if they are not able to change their mind as of now, they need to work more on that. But as an innovative paper, as a case series, this is a good paper for discussion as well.
Yeah, Amit, you're right. Yeah, Amit, you're right, because it's early. It's too early to say that this is it's a like viable options available because of the small sample size. It's better to promote the larger sample size, and we can like think about the comparative study of the 2 similar types of the osteocartilaginous reconstruction in terms of the TM joint. So we may promote the larger sample size and a good healthy number of comparative study of the same types of the flaps. Yeah, Gokul, please.
I think Akash also brought about in his critical evaluation that the authors have used this only in adult patients. Akash, I would like you to unmute and validate your point here, which is also a very, good thing that he said. It has not been used in young patients. So it is very important before we jump in to see, I think the procedure, the surgical procedure has to be understood well. And definitely the authors, as Amit said, need to, bring forward a long-term perspective of their results and see how the patients are doing. And very important to see if the movements of the TMJ can be simulated to near normal. As of now, it's only opening and closing with alloplastic. So if you're able to give back to the patient all the other movements, excursive movements as well, then I think it's a way forward, but it's too early to comment. And I think, Akash, in your critical evaluation, you did bring about these points. So kudos to that. Yeah. Yeah. So I think this is something, can we write to the authors to encourage them to work on this? And
yes.
Yeah.
Sorry to interrupt. And the other thing is the follow-up of the article. It's 12 months, Yash. I'm not against this. Please don't take me wrong. It's just critically evaluating. Tomorrow, if I have to review an article, this is how we would go an unbiased way to give a scientific-based evidence today to the youngsters, to the society, saying that yes, there is level of, as Amit rightly put it across, this is a new case innovation. We need to take it with a pinch of salt and need a larger sample size to go ahead with these kind of afflictions.
True. Agree to that.
Amit, are you there?
Yeah, I'm there, Abhay.
It's a nice to catch you here.
Right.
No, I'm on leave today. So
No wonder I saw you in the casual clothes. I wanted to ask you, are you on leave today?
so today is Raksha Bandhan. So happy Raksha Bandhan to
Happy Raksha Bandhan to everybody across India as well.
Happy Raksha Bandhan. Happy Raksha Bandhan.
Happy Raksha Bandhan to all of you. Oh, Shruti is
So,
also
Abhay,
there. Excellent. The entire team is there.
Going back to again the same thing. As we all are discussing, the same thing I told. If an innovation is published in a journal, the readership for that journal increases tremendously. That is why we are. See, I would suggest you write and letter to editor to this article.
Yeah, you should.
Okay. So this is from my point of view. If you write a small letter to editor to this article and you submit it to this journal will create a controversial discussion and it will fetch more readers for this journal, right?
Okay.
And it will impact. It will have a good impact on the readership, the global visibility, as well as the impact factor in the long run for this journal. So likewise, in every issue, we are publishing 1 or 2 letter to editors. Like, for example, everybody has got a different opinion, and it is called as constructive criticism. So,
Fantastic.
So when we do these kind of things, see, the whole community grows. Like now we all know that there is something called as microvascular reconstruction for a medial femoral condyle, and if we can simulate the movements like the lifelike TMJ, then we can definitely we will definitely go for more expertise, skill enhancement, and then more training in these kind of things. So let us take one more thing in your bag for TMJ reconstruction. So
Amit,
yeah,
with this would be my last question. I don't want to drag it along. When we speak about case studies, case reports, what would be, as an editor, what is your opinion? What validates more, a subjective or an objective based study? What I feel, it's the objective based study, assessment, which has a lot of value when you're staying level 1 evidence, rather than a subjective based assessment where the patient is assessing. Whereas Amit Dhawan, who's a microvascular guy, needs to assess, and with his other colleague, yes, this is what we have achieved. Asymmetry score is 5, symmetry score is 3. We need to be more objective rather than telling the patient, yes, tell me, how do you feel? What is your walking style? Is that change in the gait? What do you feel? It should be more objective, isn't it?
See, actually, yes. See, most of the things are subjective. But if you put in the objective assessment as well, it enhances the quality of your evidence. Sometimes the evidence is not from the case reports and case studies, the evidence is not clear, but it is guiding you towards a possible evidence in next 5 years or 3 years or maybe 10 years. So those case reports, those case series are generally accepted, which are having unique presentation or any innovation, any what is the technical note, for example. So technical note is something what Dr. Abhay is doing TJRs, and what Dr. Sarwar Hashmi is doing some technique, but somebody has done it in a different way, but the results are same, and it has made the life of the surgeon and as well as the life of the patient more easier. So that technical note gets accepted very easily, and it gives a good readership as well. So the same way, a subjective assessment is always important. Subjective assessment is always important, but if you add on the objective assessment as well, it is like putting some cinnamon in the tea, like, you know. So it will enhance the level of evidence, apparent level of evidence. Case series will not have good level of evidence, but it will enhance the apparent level of evidence. So case series will become more interesting, and the researchers can get ideas from your work that yes, objective assessment can also be added, so that you know. So this is what, for example, when an article comes, we all do subjective assessment only, because we send the article for peer review. We send the article to Dr. Abhay, Dr. Yashaswini, and it's a blinded article. So that is called as subjective assessment. So, but the authors have to do objective assessment before submitting the article. And when the reviewers' comments goes, you know, so that is the objective assessment, that yes, what is the limitation in my article, so that reviewers are pointing out, and I will, you know, do it. Let us not deviate from this point. And this is a TMJ Journal Club. Abhay, I just raised these points to enhance the quality of getting articles for Journal Club. Like Yashaswini is doing so good in running this Journal Club, but we have certain issues that most of the postgraduates, they it is a duty for us, like me and Yashaswini and all of us, to put our point that how a Journal Club article should be selected. So this is because see, a Journal Club article which poses good discussion, it's a good article. So now we are discussing since almost 1 hour. So it's a
1 hour we have been discussing. There's so much to discuss about this article, because if I keep asking and talking, it would look like I'm endorsing alloplastic TJR. It's not that. I'm keeping my mindset open. Somewhere down the line, if MFC catches up, Amit, it's a nice reconstructive option. We just need to wait, as you said, to a larger cohort of study group, sample size, better level of evidence, and it's really a good possible armamentarium. Thank you.
Thank you so much. This has been a very fruitful discussion, and that's the idea. So we have an idea in place now. There is a possibility. We are looking at a possibility. However, before we jump and delve into it, we also need to see if we can replicate it, and we have to wait for the long-term results from the authors themselves, and also see if this could be a viable option for our younger patients who are growing. So, if it is actually replacing all the components, and it gives the younger patient, as they grow, a normal TMJ function, then this could be a feasible alternate, but we need to wait and watch. So thank you so much for joining us on this session. We are actually, we are ending this in a more hopeful manner, and it will be nice to encourage the authors and write to the journal also, giving a comment on this particular article, so that the authors are also encouraged to pursue. And if they encounter a negative result, also to probably come back and say that these were the pitfalls that we encountered, and we have changed our technique, and then you move forward and try to see that we have a very feasible autogenous reconstruction. Thank you so much for giving us your 1 hour in the morning on a holiday in many parts of India. And for others, it's a working day as well. Thank you, Abhay, for your time.
Thank you,
Akash.
thank you,
I
yes.
think you did a fantastic job You did an excellent presentation. Thank you, Sarwar, for guiding him so suitably. And thanks, Shruti, Amit, and Gokul for joining
Thank you.
us.
It was a real treat to all of us, I think, to listen to all these minds come together and give so much about
Thank you.
TMG reconstruction.
Thank you, Yash.
Thank
Amit,
you,
Thank
sir.
you.
Thank you so much.
Yes.
Server, thank you.
Yes, sir. Thank you so much, sir. But
Yeah.
yes, has done like a tremendous job by organizing all these things, because since last
Absolutely.
2 weeks we were there and like a small correction, and then now almost like excellent performance by yes today. So thank
I
you
should
once again.
congratulate our server and his postgraduate for an excellent job and excellent outcome.
Yeah, Akash
It's a
is
nice
also doing
paper.
well job. Yeah, thanks,
Yeah,
Akash.
very, very
Thank you.
good.
Thank you. Very
Critical
good. Yes.
analysis under your guidance. Excellent. Keep up the good work. Keep going. Happy Raksha Bandhan to everybody across listening to us, and everybody do well.
Thanks.
Thank you so much.
We
Thank you.
will join
Thank you,
again
Yash.
next month, and it will be West Zone this time. I mean, for the next month, the turn is West Zone. So inviting articles for from the West Zone as part of the JC. Thank you so much. Have a good
Okay.
remaining
Thank you
day.
so much. Thank you so
Thank you.
much. Bye bye. Bye bye.
Bye.
Bye.